Good morning. I'd like to call the meeting of the Health and Human Services Committee to order. It's Tuesday, March 12th, 2024, and we do have a quorum present. We have several bills on the agenda today relating to healthcare workforce, and then we have a couple of others, and then this evening we will return to take up some agency policy bills. First on the agenda, we have Senate File 4444. Senator Port is here to present her bill. She does have an A1 amendment, and that is being printed, so we will have that momentarily. So, Senator Port.
Thank you, Madam Chair and members. I appreciate your time this morning. Senate File 44 is the Healthcare Employee Anti-Retaliation and Labor Act, or the HEAL Act. This is a healthcare union coalition bill supported by over 300,000 direct healthcare workers in Minnesota. Minnesota is a state that is proud of our healthcare. However, both hospital management and workers state that our hospitals are in crisis due to workforce shortages, and data shows that patient care is suffering. Looking at the data from the Minnesota Health Department, one can see that direct healthcare worker burnout is one of the leading issues in the workforce shortage. There's no amount of recruitment that can solve the crisis in our hospitals that is impacting patient care. Instead, it's finally time to listen to the workers to understand real solutions. The solution to the healthcare shortage is creating working environments where workers have what they say they need to safely and successfully provide quality patient care. To do this, we need to protect workers from retaliation when they advocate for safe patient care and ensure that they do not have to take on continued moral injury, stress, and exhaustion from not being able to provide quality patient care that they strive to deliver to their patients. Can you imagine going to work every day and knowing you will have to make decisions to ration care because you cannot physically be there to provide for all of the different needs for the patients you are assigned to care for that shift? Can you imagine seeing that harm every shift that unsafe staffing causes to patients who are people's grandparents, parents, and children? It's no wonder we have a healthcare worker shortage in Minnesota. This bill seeks to address the following trends in how Minnesota cares for patients in hospital settings. Patient safety in Minnesota continues to decline as staffing levels decline. MDH's 2022 Adverse Health Events Report cited 572 preventable events, including falls, medication errors, pressure ulcers, wrong site surgery, and patient death. Pressure ulcers, or areas of damaged skin and tissue caused by sustained pressure that reduces blood flow to vulnerable areas of the body, and patient falls made up the vast majority of the reported events. A 2022 study involving nearly 54,000 patients found that nurses' staffing levels correlated with pressure ulcers. Numerous peer-reviewed studies directly connect unsafe staffing with patient falls and pressure ulcers, as well as increased mortality rates for patients. When staff speak up because they believe they cannot safely care for a new patient, they experience retaliation. This retaliation includes being sent home, even when understaffed, not receiving vacation requests, verbal abuse, long shifts in scheduling, and being put on challenging schedules with the least preferred shift. When employers retaliate, it causes a chilling effect. When patient care staff see that their coworkers are retaliated against, it often prevents other workers from advocating for safe patient care. To combat these trends and improve patient care, this bill provides protections for direct healthcare workers in acute care settings when advocating for safe patient care. Specifically, it prohibits retaliation against patient care staff when they reasonably believe that accepting a patient care assignment would create an unnecessary danger to the patient's life, health, or safety. The bill states that this language does not pertain to patients who need emergency medical care. It also does not allow for healthcare workers to discriminate and has many protections to ensure that hospitals can respond to employee performance issues if they discriminate. The status quo is not working, and hospitals continue to make decisions that result in diminished patient care quality and workers leaving hospital jobs. It's time to ensure that we are there to support healthcare workers and improve patient safety and care. And Madam Chair, I can either move the A1 if you have it, or we can go to my testimony.
Yes, we don't have the A1 yet, so why don't we move to your testifiers? I have Chris Rubish and Ryan Hilmo, if you could come forward.
Madam Chair.
Senator Atke?
Madam Chair, what do we expect in the A1? It'd be nice to have it as they're talking, because if it's making major changes, we know that we're following along.
It was posted last night. I don't know if you can describe, I mean, it looked to me like it moved some of the sections around, but they were retained, but I don't know if you want to describe that. I mean, we should have it momentarily.
Yeah, Madam Chair, I can broadly describe the amendment. It mostly is clarifying the settings in which this would take effect, clarifying around long-term care, emergency care, nursing homes, things like that. Make sure that it is very clear and where this would take place. And I'm happy to walk through it as soon as we have it for members.
Welcome to the committee. Chris Rubish, if you would like to go first. Please state your name for the record and begin your testimony.
Thank you. My name is Chris Rubish, Chair Wiklund, committee members. Thank you for the opportunity to testify today. My name is Chris Rubish. I'm a registered nurse and the elected president of the Minnesota Nurses Association. More importantly, I'm one of the thousands of nurses across Minnesota who struggle every day because of the consistent pressures of unsafe staffing and the moral injury associated with hospitals prioritizing their bottom lines over patient care. Hospital bedside staff are in crisis. We're here today pleading for real solutions that allow us to have the safety and security to do our jobs. Dozens of objective studies prove that appropriate staffing levels in hospitals lead to better patient outcomes. Yet shift after shift, as workers appeal to hospital leaders for help with the seriously unsafe staffing levels, they are often met with indifference at best. Instead of listening to nurses who are saying in their professional judgment they cannot safely care for additional patients, hospital management consistently tells nurses to make do. But making do is causing further harm to your mother, to my father, to our grandparents and our children. In the materials in front of you today, you will see a story about how one Minnesota hospital chose to put mats on the ground and increase camera surveillance when a nurse and nursing supervisor expressed concerns about staffing levels. Despite appropriately escalating their concerns up the hospital chain of command, the management team at this hospital determined that a few extra mats on the ground was a less expensive solution than even attempting to find another nurse. Cameras and mats weren't there to help patients if they fall to the ground, and neither were the nurses whose patient assignments were already too much. I want to finish today by sharing with you the worst day of my nursing career. It's the day that I had my one and only medication error. These are not things that nurses like to acknowledge happen because we feel like we should be able to do it all. But I hope by sharing this with you today, I can show you why staffing levels are so critically important to protecting our patients. It was an incredibly busy shift. We were short on nurses, and we had no CNAs to help. I tried to object to my assignment, given that my clinical judgment made me question whether or not I could safely care for all of my patients. But I was told by my manager that there was no other option, and I had to take the assignment. I'm a young parent. I have a mortgage to pay. I can't afford to lose my job, so I had no choice. I took the assignment. I caused a medication error, and I underdosed a patient, giving them less of the medication than was prescribed. Luckily, no harm came to the patient. It was easily solved, but in that moment, I understood that the decisions we make have real effect on people's lives. I realized then the harsh reality that my nursing instinct told me that that wasn't safe and that something bad did happen. And despite the fact that no harm came to the patient, it was only by the grace of God and a little luck that I didn't harm that patient. I know that without the protections that healthcare workers need to assess and judge whether or not their assignments are safe and to object when they are critically unsafe, these types of near misses will continue to occur. Please don't leave us behind again. Please allow healthcare workers the protections they need to speak up for patient safety. Please vote yes for moving this bill here today. Thank you.
Mr. Hilmo, if you please state your name for the record and begin your testimony.
Hi, good morning, Chair Wiklund and committee members. My name is Ryan Hilmo, and I am a registered nurse. I need you to know just how real workplace retaliation is within the hospitals in your state. It's happened to so many nurses in Minnesota, where large corporate entities see the bottom line before they ever consider the dying patient. But today, I will only tell you about what happened to me personally. Last year, after keeping Nurses at the Bedside Act was no more, I arrived to work at my Alina facility cardiac unit ready for another incredibly stressful day, only to discover that the floor was not just stressful, but actually very dangerous. That day, there were 3 times as many highly acute, meaning intense amount of care, patients than what was planned. My assignment was completely unmanageable. I requested for my assignment to be changed so that my patients would get the care that they were hospitalized for, only to find out that every other nurse on the floor was in the same exact predicament I was. Shuffling our assignments was not an option. The charge nurse agreed the situation was extremely unsafe for our patients and for the nurses. I would like to remind everyone that medical errors are the 3rd leading cause of death in the U.S. That's a statistic I do not intend on contributing to, but very well could have if I would have accepted that assignment. When the charge nurse that day asked if there were any extra nurses in-house that could be spared for the safety of the unit, management said yes, but we could not have the additional nurse. After the nurses all determined we could not provide safe care, we repeated our request for safety to management. The chief nursing officer's response was to storm into our break room, call us names, say our nursing judgment was inferior to hers, threaten to terminate us, and report us to the Board of Nursing. We were told we were abandoning our patients. Then the entire cardiac unit was dismissed for the day without pay, along with being severely disciplined to boot. All I ask for is the normal amount of stress that comes with taking care of my patients. Now, added on top of that, I also have the stress of being unable to speak up for safety due to the very real and ongoing fear of intimidation and retaliation. I'm just one of many nurses that feel we cannot speak up. No one goes into healthcare to refuse patient care. That only happens in the most extreme and dangerous of conditions. Senate File 4444 would put the responsibility of patient safety on the company that promises quality care for patients, instead of the staff who are continually required to do more and more with less and have very limited input into these circumstances. I ask that you please support Senate File 4444. Thank you for your time and consideration.
Thank you very much. Members, we do have the A1 amendment now, and Senator Port, if you, can you just walk through briefly how this fits into the bill, and then we'll adopt the A1, and then we can move on to the rest of your testimony.
Yeah, thank you, Madam Chair. I can broadly describe it, and also if Katie, if you want to come up too. Originally, the bill had some less than clear language, some ambiguous language, and so this really clarifies that it is acute care settings and agency care facilities. And I also want to reference members to the second page of the amendment, which I think is a critical piece. It requires that contact information for who the nurses are supposed to call when they are requesting assistance for an unsafe actually has to be provided, which is a consistent sort of problem calling up the chain. If you don't actually have contact information to do that, a nurse can't fulfill that part, and is often sort of part of the retaliation is, well, you didn't call up this chain. Well, you didn't give us the numbers to do that. And so it requires that those numbers are provided ahead of time. Katie, do you want to add anything?
Can you state your name for the record, please? And
Madam Chair, Katie Cottonbrook. I work at the Minnesota Nurses Association. As Senator Port said, it is really just clarifying that this is acute care settings and state agency settings for the bill language instead of long-term care and additional facilities.
Thank you. Members, I'd like to adopt the A1 since it's an author's amendment, and then
Madam Chair, I'll move it if you'd like.
Senator Abler moves the A1 amendment. All those in favor, please signify by saying aye. Aye. Any opposed? The amendment is adopted. Thank you. And now, would you like to have your additional, there's two more testifiers? Okay.
Please.
Chelsea Shafter, I'm sorry if I mispronounce your name, and Rachel Ballard.
Hello, I'm Chelsea Shafter.
Welcome to the committee, and yes.
Thank you. Good morning. Thank you, Madam Chair and committee members for the chance to testify this morning. My name is Chelsea Shafter, and I'm a registered nurse. I'm here today to speak to you about Senate File 4444, the Healthcare Employee Anti-Retaliation and Labor Act, and the importance of this bill, not just for nurses, but for healthcare workers in the state of Minnesota. I have experienced firsthand the struggle of making this decision between, do I accept this unsafe patient assignment, risk patient harm in my nursing license, or do I risk being given a scarlet letter per se by my employer, which could lead to me being retaliated against in a multitude of ways, up to termination, thus affecting my livelihood. In both scenarios, it's a lose-lose for the nurse. The employer I worked for promoted a culture of speaking up if you had concerns around safety, if it did not affect their bottom line. I have heard the concerns that this bill will lead to unit closures, delays in care, and increased ER boarding, all of which are occurring most days in healthcare facilities across the state without this bill in place. That is because the real fear instilled in us by our employers. As a registered nurse, you are required to wear a lot of hats, and with that comes a sort of expertise in problem solving and making it work. Those times where we cannot make it work safely, we need to have the ability to speak up, be heard, and have those situations addressed so we can do our work safely. We are asking for the onus to be placed on the employer to provide nurses with the staffing and resources needed to do their work safely, not use their judgment to unilaterally decide what is safe and what is not. Especially when, per the Minnesota Board of Nursing, it is the responsibility of the nurse to advocate for the best interests of individual patients and provide safe and effective nursing care. We need to promote a culture where nurses can speak up about safety and be met with support from our employers, not retaliation. Senate File 4444 can do this. Nurses feeling safe and supported to speak up in their workplaces, which in turn creates a safe environment for patients receiving care. This is one way we can retain nurses at the bedside, because when you have more nurses, you have increased patient flow from the emergency departments, as there are units open, beds staffed to take patients, and nurses with the resources to provide complete holistic care every patient deserves.
Thank you very much for your testimony. Rachel Ballard, please state your name for the record and begin.
Hi, my name is Rachel Ballard, and I'm a nurse at Abbott Northwestern Hospital. Chair Wiklund, committee members, thank you for allowing me to testify today in support of the HEAL Act. Hospital management will tell you that this legislation will allow caregivers like me to discriminate against our patients by refusing to care for them based on our racism, homophobia, and other biases. Of course, they'll fail to mention that the language in this bill strictly prohibits discrimination. They might also tell you that this bill is unnecessary, really, because they don't retaliate against their employees anyway. As a union rep for nearly 2,000 nurses who sits in their discipline meetings, I can tell you that could not be further from the truth. The reality is, in the absence of statutory minimums on staffing, it falls on individual nurses like myself and Chelsea and Chris to protect our patients from dangers in the clinical setting. When management attempts to give a nurse her sixth unstable and totally dependent patient, it falls on the individual nurse to say, hey, you need to bring in additional personnel. I'm stretched too thin and a patient might get hurt. When a nurse who is untrained and uncertified in heart monitoring is ordered to float to a specialized cardiac tele unit, they must stand up alone and say, "You know that I don't have the training for that specialty. Find an appropriate nurse so that those patients can get the care that they deserve." Every day, nurses are the last line of defense between patients and the irresponsible choices of hospital management. And when courageous nurses stand up, they face intimidation and discipline, a fact which is supported by the peer-reviewed literature. Research further shows that when nurses don't report concerns, it is the fear of retaliation that's holding them back. And of course, it is Black and brown healthcare workers who are most likely to be made an example of and to face retaliation, leading to higher rates of burnout and attrition among our BIPOC staff, who are at the forefront of correcting disparate outcomes. When workers are too afraid to defend a safe care environment, it is the most vulnerable patients, our BIPOC and transgender patients, our non-English speaking patients, our unhoused patients. They are the most likely to slip through the cracks and experience adverse outcomes. This is your opportunity to protect healthcare workers, especially healthcare workers of color like myself, from retaliation as we stand up for our patients' safety. Pass SF 4444, the HEAL Act, today. Thank you.
Thank you very much for your testimony. Next we'll go, there's 2 testifiers online, and then we will go back to some in-person testifiers. First on Zoom, we have David, and I apologize if I spell or pronounce your name incorrectly, Klana. And please state your name for the record and begin your testimony.
Yes. Good morning, Madam Chair and members. I am David Klana. I coordinate volunteer services at the Minnesota Sex Offender Program in Moose Lake. Thank you for the opportunity to testify in support of Senate File 4444 as a Minnesota Association of Professional Employees member. I support volunteers in providing spiritual and support group services, working in a secure therapeutic environment with many colleagues and about 150 clients. Working with these clients is challenging, especially with high turnover and chronic understaffing. That said, I truly enjoy the work. I wish I didn't need to testify as tasks pile up and colleagues feel extra stress. Other colleagues wanted to testify, but one of them, a clinician, declined, stating, "I would miss my client's only treatment group of the week, and I can't in good conscience to my clients miss their only group." The other colleague could not testify because of a short-staffed department, vulnerable to security coverage being pulled at a moment's notice. I wish I could say we work in a consistently safe environment and a culture responsive to staff feedback concerning staffing and safety issues. Sadly, that has not been our daily experience, and we are not alone. I am therefore here to speak for myself and colleagues from various bargaining units who frequently feel caught between a rock and a hard place, having to do tasks when they do not feel safe, yet fearing if they speak up, they will be disciplined. This involves direct safety situations, but also being frequently forced to work double shifts, being reassigned repeatedly during shifts, and being discouraged from working on representational issues. Colleagues also share concerns about the high turnover rate. They state that people leave when given impossible tasks, feeling inadequately supported or unfairly disciplined, or observing questionable discipline targeted toward people who speak up about safety issues. These dynamics make it more difficult to recruit or retain enough capable colleagues to deliver the high-quality programming needed to rehabilitate clients in an environment safe for everyone. Without sufficient experienced staff, clients who may not be ready could be prematurely released into the community. Also, clients with potential and motivation to do their work and return home can be delayed in their journeys with extra taxpayer cost. This bill would allow staff to request modified work assignments without retaliation and provide therapeutic rehabilitative staff in state facilities overdue protections to confidently share both patient and staff safety concerns with supervisors. After clients assaulted 5 colleagues at Moose Lake MSOP last year. The status quo clearly does not work. Please support Senate File 4444. Please give patient care staff stronger, more secure voices in our workplaces. Thank you.
Thank you. The next testifier on Zoom is Kelly Hagan. If you could please state your name for the record and begin your testimony.
Yes, good morning, Madam Chair and committee members. I'm hoping you can hear me all right. My name is Kelly Hagan. I'm the Chief Nursing Officer at Rainy Lake Medical Center in International Falls, Minnesota. This is a 25-bed critical access hospital. I've been a registered nurse for more than 40 years and a nurse leader for more than 20 of those years. I am proud to be a nurse and nurse leader, and I'm grateful for this opportunity to represent my colleagues today. I'd like to talk about how hospitals staff their units and how difficult it would be to operationalize the situation when and if a nurse were to refuse their patient assignment. We obviously look at nurses' skill set, their expertise, how many years of experience they have, and what type of hospital unit they are suited best for. Hospitals obviously match educational experience with those appropriate units. All hospitals have staffing plans that are publicly reported with quarterly information about the actual staffing levels and number of patients. Of course, life happens, and sometimes hospitals get busier than anticipated. Hospitals are constantly adding additional nurses to shifts, particularly when nurses call in sick and sometimes on relatively short notice. I want to relate that we do not have staff waiting in the wings to come in and work. We do have a communication process to identify and contact additional resources when needed. If we are not able to identify additional resources then to support, then nursing leaders, supervisors, directors, and CNOs come in to provide direct patient care. For example, recently when a patient's condition changed and our census increased, we communicated our need and asked folks to step up and come in to close the gap. And we all know that doesn't always happen, and so we draw on the resources that we have. But that is different than a nurse refusing a patient assignment. Under this scenario, the nurse is still at work and doesn't want to care for a particular patient or doesn't feel they can. The charge or lead nurse may be able to change that nurse's assignment or move them to a different unit. But that is not always possible based on the skill and expertise of the nurse, as well as the skill and expertise of other available nurses. Sometimes it's possible to bring in additional nurses, but that may take some time to get them here, up to 30 minutes or more, depending where they're coming from. Hospitals all have procedures in place for dealing with staffing requests, and hospitals with collective bargaining agreements have this process laid out and very detailed. Language allowing a nurse to refuse to care for a patient once that patient has been admitted to the hospital should not be put into statute. Putting this in place compounds the patient care and safety issue and does not help it at all. We do not participate or support in retaliation. I ask you to repeal this. Thank you for your time and attention to this matter today.
Thank you very much for your testimony. Next, we'll move to some additional in-person testifiers. I have Adam Carlin, if you could come forward, and Ethan Vogel. Welcome to the committee. Please state your name for the record and begin.
Madam Chair, my name is Adam Carlin. I'm the Chief Nursing Officer at M Health Fairview Southdale Hospital. I've been a registered nurse for 15 years, including 9 years in varying leadership roles. I'm proud to be a nurse leader, and I'm grateful for the opportunity to represent my colleagues today. To put it simply, I have grave concerns with Section 5 of this bill, which authorizes a nurse to unilaterally refuse with impunity to accept a patient. This provision has the potential to confine some of our most vulnerable patients, including those experiencing mental health crises, to our extremely busy emergency departments. This bill creates significant opportunity for individual bias to determine who receives care in our hospitals, bias to which our nursing profession is not immune. High-quality care requires a team, teams that work around the clock to create safe working environments for our patients and colleagues, teams that work together to determine, in a very delicate balance, to determine the best location for patients under our care. The legal sanction of patient refusal for one role within the broader healthcare team disrupts this delicate balance. It recklessly endangers patients and would significantly limit our ability to ensure reliable access to hospital care for all patients. To be clear, hospitals in Minnesota are not interested in retaliating against our staff. In fact, most hospitals in Minnesota have a non-retaliation clause in their code of conduct. The authors of this bill have used the term retaliation to describe professional nursing accountability with respect to patient refusal. Minnesota already has strong whistleblower legislation with important protections for individuals who, in good faith, report situations in which the quality of care services is in question. This law protects nurses that speak up. There is no substantive proof that nurses who raise legitimate patient concerns face retribution from their employer on a widespread basis. In fact, at Fairview, our Safety Always culture requires staff who have questions and concerns to speak up, to practice a questioning attitude, and to communicate clearly when there are issues. The authors of this bill mistakenly confused retaliation for accountability. In the case of Section 5, which gives nurses the unilateral authority to refuse patients, this lack of accountability will create serious problems. It is important for this committee to consider the impact this proposed legislation would have on our underserved, marginalized, and vulnerable patients we care for in our hospitals every day. In an increasingly polarized world, it is not a bridge too far to see this provision used to the extreme, giving people with conscious or unconscious bias the ability to pick or choose their patients. Under this law, a nurse can simply say, "I refuse, and I am not going to talk about it until I have representation." We have existing whistleblower laws. We have existing internal processes and protocols to support care in our hospitals. We will continue to oppose this provision. Thank you.
Thank you. Next, Mr. Vogel, please state your name for the record and begin your testimony.
Thank you, Madam Chair, and good morning, members. My name is Ethan Vogel, and I serve as Legislative Director for AFSCME Council 5. AFSCME is a public and private sector labor union, and at Council 5, we represent roughly 43,000 workers across 248 locals and sublocals in Minnesota. Among these locals are AFSCME members who work at Regions Hospital, Hennepin County Medical Center, Anoka Metro Regional Treatment Center, mHealth Fairview, state-operated forensic services in St. Peter, regional community behavioral health hospitals, and other acute care settings. It's hard to compare the work performed across these healthcare facilities. Each present their own set of unique and sometimes extremely challenging circumstances for frontline staff. A commonality, however, is that the success of each of these hospitals and all healthcare settings in our state depends on leaders engaging with and listening to frontline workers. AFSCME Council 5 strongly supports Senate File 4444. We view this as a step in the right direction to improving the engagement process with frontline workers. The labor protections for frontline direct patient care staff incorporated in this proposal will serve to strengthen the relationship between those who are directly delivering the services and those who are making macro-level decisions around service delivery. Thank you for your time and consideration. And I will, in closing, just note to a letter of support we've submitted for Senate File 4444, Senate File 4382, and Senate File 4064. Thank you.
Thank you very much. The next two testifiers, I have Brad Leto and Diana Testa-Damer, and I apologize if I mispronounce your name. Welcome to the committee. Please state your name for the record and begin your testimony.
Thank you, Madam Chair. I'm sorry, I woke up with a little bit hoarse. I don't know why, but thank you. Good morning. My name is Brad Leto. I'm the Secretary Treasurer of the Minnesota AFL-CIO, the collective voice of Minnesota's unions. Thank you, Chair Wiklund and members of the Health and Human Services Committee for the opportunity to testify today. Obviously, I'm here to support Senate File 4444, the Healthcare Employee Anti-Retaliation and Labor Act, the HEAL Act. Thank you, Senator Port, for authoring this bill. Senate 4444, as you've heard, protects, and I will change my testimony slightly as not to repeat, protects workers from retaliation for taking on too many patients. An additional assignment may create unnecessary danger to a patient's health, safety, or life. The bill establishes a process, however, that must be followed before patient safety. As Senator Port explained well, retaliation takes many forms. And I won't go through them again, but will say that in the House, there was a nurse that testified that he complained about too many patients, was sent home. And there was a question as far as, well, if you were sent home, wouldn't that lead to less staffing? And in response to that question, he said, well, they just had the staff that just finished their shift stay on for another shift. That doesn't sound overly safe as well. It is obvious we do not have enough patient staff in this state. And we have an even more acute shortage, and you heard from a testimony from an excellent person, but an acute shortage of BIPOC, Black, Indigenous, people of color patient care staff. Progress is being made as more and more BIPOC patient staff are entering the field. Do we really want to jeopardize this process? Do we want to continue to overload the current patient staff and have even more healthcare professionals leave their jobs? Everyone has a breaking point with their jobs. As you've heard from testimony, you will hear more. The Minnesota AFL-CIO, the Minnesota Nurses Association, ASBE, Council 5 and 65, SEI Healthcare, Minnesota and Iowa, and you'll hear from Diane, the local Food and Commercial Workers, Local 1189, the United Steelworkers, and you've heard from MAPE, all support this bill. These unions believe that, again, everyone has a breaking point in their jobs. Senate 4444 tries to alleviate that breaking point. This bill tries in one small way to heal the patient care system with protections for care workers on the front lines of the fight to improve our healthcare system for workers, patients, and families. The Minnesota AFL-CIO asks for you to support Senate File 4444. Thank you for your time.
Thank you for your testimony. Welcome to the committee. Please state your name for the record and begin.
Yeah, thank you, Chair Wiklund and committee members. My name is Diana Testa-Damer, and I'm the Legislative and Political Director with the United Food and Commercial Workers Union, Local 1189. We represent about 3,000 healthcare members across Minnesota, mostly in long-term care, but we also represent some certified nursing assistants in acute hospital settings in the Duluth area. I am here to testify today in support of Senate File 4444. As we continue to see staffing in healthcare facilities across the state put patients and workers at risk, and it's time for a legislative fix for the crisis in our hospitals. In healthcare, the workers who provide direct patient care often tend to primarily be women and BIPOC workers. Our workers are vital for Minnesota's healthcare industry, and we know what patients need as they provide support and care. Yet when you look at the power structure in healthcare facilities, those who provide direct care are those with the least amount of power. Though the power structure is skewed against these workers and they have little to no say in what staffing looks like, they take the primary responsibility for patient care and must bear the burden, sometimes even losing their jobs, if there are issues that result from unsafe staffing. This pressure is only further multiplied when they experience retaliation for stating they are not trained to provide the care they are assigned or cannot be physically in all the places they need to be to help their patients. Data shows that BIPOC workers experience higher rates of retaliation than their white peers. The U.S. Equal Opportunity Commission, or EEOC, reports that while applicants and employers in all industries experience retaliation, research shows that workers of color are more likely than others to be fired when they report the violations. The fear of economic harms leaves workers feeling less willing to risk retaliation than by challenging workplace violations. The workers who are most intimately connected to ensuring that patients receive quality care and know what patients need are also the ones most likely to experience retaliation for speaking up when they advocate. Worker voices need to be protected to improve patient care and fix the crisis in our hospitals. Please vote to support the HEAL Act and help decrease retaliation against those who are fighting for your family members and loved ones in the hospitals. Thank you.
Thank you very much. That concludes all of the testifiers that we have. And now I would like to move to member questions. Members, Senator Utke.
Thank you, Madam Chair. I guess I'll start this off, and this language is what I consider or we'll call it, it's a bad bill this year. It's been a bad bill every year that it's come up. This doesn't help our situation. We are all concerned with our nurses, which is the center of this bill. And as we sit around this place day after day, we're concerned about our workforce in general. We want to do what's best for them, but this bill will not do that. I've heard about shots taken at these nasty corporations and all about the bottom line. Well, last year, as an example, 66% of our hospitals ran in the red. They're concerned about their bottom line because they're trying to keep the doors open. But that's not at the expense of our nurses. Members, we need to talk about the real issue here, and that's not this nursing ratio bill or they're able to turn away patients or whatever you want to call it. But they're being overloaded because our hospitals are full of people with mental health issues that are supposed to have been discharged, but yet they're stuck in the hospital. Last year, we had 195,000 patient days, which means that we're, of course, non-paid, but that means that number of days, nurses and other staff are having to take care of these patients that should have been discharged to a different type of facility, but we don't have it available in the state. That's got to be a priority, because if we could get those patients out of the hospital, now they wouldn't have such a shortage. The nurses that are there would be able to take care of the patients that they are there to take care of and not have to watch over the rest of these also. So we need to drill down and talk about this root cause, because passing this bill would do absolutely nothing for that. Actually, it's going to make it worse. We've got some bills coming up later today that once again are going to take additional personnel from a hospital and make them cover another area. Again, how are we going to take care of patients when we don't have the people? Let's do what's right, and let's work towards freeing up their schedules so that they can do what they are trained to do and want to do, which would be taking care of patients. But please do not push this bill forward, because this will not help our providers at all. Thank you.
Senator Abler.
Well, thank you, and I appreciate the discussion, and I agree with about 3/4 of what my good colleague on my side of the aisle, not across the aisle, said. It is a problem, and one thing I'll just add on to all the causes that Senator Utke mentioned are true, including one more, which is the expansion of the state and federally funded health programs that many want to expand even more. I think Ms. North Memorial at 64% or something like that of state-funded programs. And there's not an entity that can make a living on Medicaid. And Minnesota Care is not a lot better. And Medicare is the rich pot of that. And over, physicians and other groups say they can't live on those rates. So I just want to continue to bring that up as we considering adding more people to that. We're just going to add the undocumented next year, I think, are going to be thrown into that pot. And while it's better than nothing. But Madam Chair and members, I do think there's a problem. But I think every hospital is not as challenged as the rest. We got a couple notes from some small hospitals in greater Minnesota, and they're just trying to stay open. And I bet they have a pretty good rapport with their nurses and their staff. But, the one that I have in my area, Lina, it's going so well, the doctors had to unionize. I was like, seriously, And they're benchmarking. They're trying to keep up with maybe Mississippi or something for their ratios, and just an irrational, random number. And so I was shocked that MSOP had to come down. I thought that as a state employee, they were taken better care of. And so there are problems. And at my AMRTC, nurses get hurt every day, or at least frequently, all the time up there by people, if they're patients or clients, I don't know what we call them, but that are injuring these staff, and they're not even allowed to protect themselves except to back up. And so, holy cow, why would you even want to do this? You know, and so we try to get a pipeline going in. There's a bill up for loan forgiveness, you know, hey, come be a nurse, it's a great job. And there's a lot of rewards, and people go in for the right reasons, but they don't go to get hurt. They don't go to be professionally burdened with providing inadequate coverage. And you know, is the bill perfect? Well, probably not. I think I'm going to add on as an author. I don't know how I got missed on this one, because I support the effort to make our system whole again. And I don't know that Allina is driven purely by profits. I think they want to survive. But at some point, when things have all consolidated, and now Allina is the only thing going in my area, there's no independent docs hardly anymore. And so that was the great plan. And then, so I think that, I just know the most about my own area, but I think Allina has a responsibility. And there's a bill coming up about closures. They can just on their own decide to close the OR and ICU and think they're going to all land at Mercy, where there's not room, where it's 1/3 full of people that are camping out there that should be somewhere else, and closing the pediatrics department suddenly without any public notice on the pediatric mental health. So then we're going to make the nurses just do more and more work. And by the way, you can handle one more. We know you can. So just, you know, just be quiet and go do it. And then the young nurse who made his medication error, what if that would have been your mom or somebody? So they're not crying wolf, Madam Chair. And the discussions need to go on. And I think to the nurses, if there's a way to help the ones that are actually doing really well to be a little less, you know, burdened than the ones that need a little more pressure to have that, I think that would be a way to go. But good luck, Senator Port. I'm with you. Thank you.
Thank you. Any other questions? Senator Mann, sorry.
Thank you, Madam Chair. So our healthcare system is complete trash. We all know this. Hospitals are closing all over the place, right? Eau Claire, Chippewa Falls. Units are closing all over the place. New Prague, Hastings, and Faribault are talking about closing OB units. Pediatric units are closing. So the system is not working as it is. And you have my commitment to continue to working on changing the system, because what happens at the end of the day is that patients are not getting the care that they need to the level that they deserve. This is all absolutely true. And we as providers are asked to take on more and more. This is absolutely true. My concern is that, and I've talked to Senator Port about this, is that what happens to that patient at the end of the day? That patient is, you know, I can't take another patient because it's unsafe. That patient ends up in the ER. There's no other place for that patient to go. So yes, we have an ER boarding crisis, but that doesn't mean that we should do things to make it worse. So this patient ends up in the ER where they're getting even less accurate and deserving care than they would on an overstaffed floor. Because the moment that a patient walks in with a stroke or a heart attack, that patient who is now boarding has 0 nurses. 0. No one is paying attention to that patient anymore because we are all in crisis mode in the ER. So my concern is that while we are trying to make these little steps, right, and we've talked about this before, these tiny little Band-Aids on this crumbling healthcare infrastructure, that we put patients at increased risk while we're trying to change the system. And that is something that I do not want to do, and I do not feel comfortable doing, is risking patients and putting them in even riskier situations. And then we talk about discrimination. I mean, whether it's legal or illegal, it's going to happen, right? If it were as easy as to put it on a page saying that's illegal, we solve the problem, we would not be talking about this problem anywhere ever. So it's still going to happen. And imagine you're already overworked, and the next patient that they say you have to take is a non-English speaker, which we know we're going to be in that room twice as long as any other room. How easy is it going to be to say no to that person? So for all those reasons, I don't feel comfortable with the language as written, but I do think that I understand what the issue is. I don't want to see patients suffer. I don't want to see us be nervous at work, because I know I'm nervous at work all the time because my ER is completely full and it's awful and I don't want to be there and the nurses don't want to be there. So we have a lot of work to do. I just, this one, I don't quite think it's going to solve the issue.
Senator Port.
Thank you, Madam Chair, and Senator Mann, thank you. We've had conversations about this bill, and your question about what happens to that patient is a valid one. My goal with this bill is that what happens to that patient is another staff member gets called in. But this isn't a silver bullet. It's a crumbling infrastructure, as you said. And the goal of this legislation is to safely staff patients to the level that they should be at. And right now, that burden falls disproportionately on the shoulders of bedside caregivers. And to be clear, the Nurse Practitioner Act that already exists tells nurses you have to do this. You have to say something when you have an unsafe work assignment. And the problem is they're being retaliated against, or it's a ridiculous system of 15 call-ups you need to do to get to the person who approves that a 24-year-old on the night shift isn't going to feel comfortable doing. It's the process is broken. That is just clear. It should be a partnership between hospitals, caregivers, doctors, nurses. The whole system should work as a partnership to get patients the care they need. And you're absolutely right, Dr. Mann, it's broken. And my hope with this bill is to fix one piece of it, but that also feels like trying to put a Band-Aid on a broken dam. It's only one piece, but it feels like an important piece to protect those folks at the bedside who are doing the work in the hardest moments, to say, when you say you need help, you can't be retaliated against. That's the goal of this bill. I'm happy to work with you on language to make sure that's right, because I think your discrimination pieces are a very real concern. Also, in that nurses of color are most likely to be discriminated against in these cases, or be retaliated against. And so I think we can work together on strengthening that. I'd love to work with you on it. I think we all know that it's a problem that needs to be fixed, and I want to be a partner in that.
Thank you. Senator Boldon.
Thank you, Madam Chair. Thank you, Senator Port, for bringing this bill. I appreciate the discussion that we are having this morning. It's an important topic, and I appreciate the different perspectives, especially Dr. Senator Mann, yours as well. I agree. Our healthcare system, the system we are in right now, is failing people and harming people every day on both sides of the bed, patients and staff. And so we absolutely have to build a system that is focused around care versus profits, and that really is meeting the needs of our community members, and I'm committed to that work. And so this bill is not going to fix all of the issues that we have in our healthcare system, but I think it is also important, and I want to thank the testifiers who came to tell your stories today, the nurses who, it is difficult to talk about when you made an error in front of everyone, but it's important, so thank you for doing that. I'm a little troubled, discouraged at some of the dismissals that we have heard also in testimony today of those experiences. The experiences, we should be listening to nurses. Nurses are telling us there is a problem, this is an issue, we are experiencing retaliation, and we should believe them, we should listen to them. And I want to just reiterate, Senator Port, what you just said about, as nurses, in our Nurse Practice Act, we are already required to do this. I'll just say, we are, the following grounds are subject for disciplinary action. Any nursing practice that may create unnecessary danger to a patient's life, health, or safety. We are already required to speak up when we are seeing a patient's safety at risk. So on the one hand, we're required to do that. On the other hand, when we do that, we're facing retaliation. So it puts nurses in a really difficult spot. And so I appreciate that perhaps the language isn't perfect and there's ways to ensure that, it's safeguards and that it really is getting at the issue that we need to get to. And I appreciate your willingness to continue to work to get there. I appreciate your comments around, the goal isn't to have patients be moved to the ED. The goal is to have more staff to be able to take care of patients. And maybe that's moving staff around. Maybe that's a nurse manager takes a patient assignment. But, there's ways to be creative. But the reality is the longer we continue in a system where nurses are retaliated against, demoralized, injured at work, all of these things, nurses are going to continue to leave. And so we have to start addressing some of these issues. And when we talk about, we are all concerned about nurses, then we should listen to nurses and take steps to help them in their work. So thank you.
Thank you. Any other members have questions or comments? Senator Port, any final comments?
I appreciate everyone's time. Happy to continue working towards solutions. Thank you very much.
Thank you. This bill needs to be referred to the Committee on Labor. And Senator Abler, would you move that Senate File 4444 as amended be recommended to pass and be referred to the Committee on Labor?
So moved.
Thank you. Members, all those in favor, please signify by saying aye. Aye. Any opposed? No. The motion does prevail. Senate File 4444 as amended does pass and is referred to the Committee on Labor.
Thank you, Madam Chair.
Members, we are going to take a 5 to 10 minute recess and we will be back. I'd like to call the meeting back to order. Members, I would like to call the meeting back to order. We have the next bill on the agenda is Senate File 4101. Senator Mohamed, welcome to the committee.
Thank you, Madam Chair.
Can we please have quiet in the room so Senator Mohamed can present her bill? Thank you.
Thank you, Madam Chair. Good morning, committee members. Before you is Senate File 4101, which will expand funding and eligibility for nurses struggling to enter or stay in bedside nursing. This bill extends the program that the legislature created last year, which provides student loan forgiveness for registered nurses in acute care settings. The demand has far exceeded the expectations, with more than 10 times as many applicants are there available grants. For this reason, we will be seeking to extend the program with few suggested improvements. Eliminate the supervisor's recommendation letter requirement, which can pose challenges for non-affiliated nurses. Remove essay requirements to alleviate barriers to entry and ensure fairness through lottery system. Introduce a 3-year bedside RN employment prerequisite to foster a commitment to this career. And I believe we have one-time funding of around $25 million for the year 2025 into the account. And I've got some testifiers with me, Madam Chair. Thank you.
Yeah, and thank you, Senator Mohamed. And there is an A1 amendment.
Correct.
If that could be passed out. Okay. It is, oh, I'm sorry. I didn't see it here, sorry. So Senator Kupec moves the A1 author's amendment. All those in favor, please signify by saying aye. Aye. Any opposed? The amendment is adopted. And for testifiers, I have Rachel Hanneman. Welcome to the committee. Please state your name for the record and begin your testimony.
Hi, thank you. Good morning, Madam Chair, Wiklund, and committee members. My name is Rachel Hanneman. I'm a BSN RN working in the emergency department and ICU at Fairview Southdale in Edina. I've been a nurse for a long time. It's 3 years as an LPN and 8 years as an RN. The process for applying and becoming admitted into a nursing school is long, tedious, and can often require rejection and reapplication to even begin the program. I myself applied to nursing school 3 times before being accepted into an LPN program. After 2 years of schooling and my first year as a nurse, I was accepted into a BSN program and finished in 2 years. From the time I began pursuing my degree to the time I graduated, I spent 7 years in school earning a 4-year degree. The career has been exponentially more tedious than the education, and often we at the bedside crave reminders of what propelled us into the career. Let me assure you that reminder is not in the $603 monthly bill that I pay because of the loans I was required to take out in becoming a nurse. There's currently only one route to become a nurse, and that is with a licensing exam following a college education. I am far from alone in my experience. Many of us come from families that couldn't afford to help us through college. Most of us will rely on the promise of the PSLF to help alleviate the burden of our monthly loans. This only comes after 10 years of full-time work for a not-for-profit employer. If life events like having children, caring for loved ones, or personal illness put limits on your ability to work, you lose qualifications for forgiveness. The cost of education is enough to deter many future applicants from entering a nursing program or advancing the degree they already have. I have coworkers who talk about wanting to go to school but can't afford the tuition and are absolutely intimidated by the debt. This is a removable barrier. With the nursing degree, there are nearly endless possibilities for utilization. A single nursing degree can provide care in a hospital, a nursing or group home, a public school, or even volunteer opportunities. These are all benefits Minnesota deserves, and the nurses willing to provide them deserve relief. Providing student loan forgiveness would uplift the quality of life for current and aspiring nurses across the state and help keep nurses in critical hospital roles. Thank you.
Thank you. That's the only testifier I have on the list. Does that seem correct?
That is correct.
Okay. Members, any questions or comments about the bill? Senator Utke.
Thank you, thank you, Madam Chair. For clarification, Senator Mohamed, did you say that this was going to be like a $25 million appropriation?
That's a,
Senator Mohamed.
Madam Chair. Thank you, Senator. Okay, that's a good question. In the bill, we have $25 million one time in for 2025.
Senator Utke.
Thank you, Madam Chair. I was still looking for that because I saw where it was $5 million, a little over $5 million. But anyhow, that'll wash out, I guess, through as this thing moves forward. Either way, it's just, I support the various, some of these loan forgiveness programs, but just, I guess, for your sake here today, I'll just let you know, there's no way I can support this only because the money is coming from the Healthcare Access Fund. If it was coming from a different source, I'd be supportive, but because of that, I would have to say no today.
Senator Utke, the appropriation that we're talking about is Section 9, and that is a general fund appropriation. So just the Section 9 on page 21, and that is a general fund appropriation. So,
Madam Chair?
Senator Utke.
Taking a look at, this is on page 3, creation of an account. Okay, that's just, okay, that's, the account is being established in the Healthcare Access Fund, is that correct?
Yes.
Okay.
That's correct.
So it is general fund monies?
Yes.
Okay, thank you.
Okay. Thank you. Members, any other questions or comments? Senator Morrison.
Thank you, Madam Chair, and thank you, Senator Mohamed, for bringing this important bill forward. Do you have an estimate of how many nursing students this amount might help?
That is,
Senator Mohamed.
Madam Chair, Senator Morrison, that is a really good question. I'll have to phone a friend and ask that. I know Katie is here.
State your name for the record then and proceed.
Thank you, Madam Chair. Katie Cottonbrook with the Minnesota Nurses Association. understanding with the program that's passed last year and has in the process of being implemented, there were about 300 registered nurses who were qualified for the grant program. And we know that there were over 10 times more applicants than those who are able to receive the grants.
Senator Morrison?
Thank you, Madam Chair. That's great. Thank you.
Any other comments or questions? I don't see any. Any final comments, Senator Mohamed?
Thank you for your time, and I appreciate you for hearing the bill today.
Thank you. And so Senate File 4101 will be laid over for possible inclusion in an omnibus bill. Members, we're going to skip to the, excuse me, the last two bills that I have on the agenda. Senator Kupec has an amendment that's being drafted and printed, so we're going to do the last two bills first. Senator Mann will take over for chair.
Madam Chair, when you're ready.
Thank you, Madam Chair. I have Senate File 4699. Senate File 4699 is a bill that is technical correction for allocation or appropriation that we made last year in the HHS Omnibus bill. There was a grant to if you look on page 12 of the bill, there was a grant to the Minnesota Alliance for Volunteer Advancement that we had included in the bill and was included on the spreadsheet, but the language did not get included in the bill language. And so after session, we recognized that this language was missing. Myself and Chair Liebling, we wrote a letter, and Senator Etke was, I think you were involved in that as well, to state that we, the intent was to make the appropriation, and so that the Department of Health could go forward with it. And now we want to make sure that we get the language in place so that documentation exists that we were allocating this funding to the Minnesota Alliance for Volunteer Advancement. This bill will also be the bill that we will use as a vehicle for if we have budget appropriations that we end up including in a bill. So it's a vehicle, and we also want to take care of this technical correction.
Members' questions? Seeing none.
Senator Etke, did you?
Senator Etke.
Well, I don't have to jump in to just thank you, because they did, you guys did a lot of work on it, but this group really worked their tail out to get this through because of exactly what you explained, so thank you.
Other comments? Okay, so the motion is to lay, this bill will be laid over.
Thank you.
And on to Senate File 2437.
And Senate File 2437 is a bill that we took up in our committee last year. This is a bill that we would like it. We had sent it to the floor for use. It matches up with a bill in the House that Chair Pinto has, and so this is a vehicle bill for possible use later on in session. And so we would like to refer it back to the floor, or pass it and send it back to the floor, because it was at the floor, but then returned to the committee after session was over.
Members? Okay, so the motion is that Senate File 2437 be recommended to pass. All those in favor signify by saying aye.
Aye.
All those opposed? The motion prevails.
Thank you. And I don't know if we're closer to having that amendment ready, or? We will move now to Senate File 4382, Senator Kupec. You want to proceed to present your bill?
Sure. Thank you, Madam Chair. And so I do have an author's amendment, which I think is in the process of being drafted and printed. Would you like me to do the general layout of the bill before that?
Yes, if you could do that, and then we should have the amendment shortly.
Sure. Okay. So I'm going to start with a little bit maybe of a sports analogy here. So do we remember back in the day, the Baltimore Colts? Do we remember the Baltimore Colts that in the middle of the night packed up their trucks and left to Indianapolis, and away they went? There was no more Baltimore Colts. And those fans in Baltimore, they were heartbroken that the fact that their football team had moved out to the West. I personally, I grew up in Connecticut, and people will always ask me if I'm a Minnesota Wild fan, and I say, my hockey team no longer exists because I was a Hartford Whalers fan, which also, I will add, has the greatest logo of any hockey team ever, but that's my personal opinion. But they, too, sort of packed up in the middle of the night, and away they went down to the Carolinas, and now they're the Carolina Hurricanes. So all those sports fans, they are heartbroken on when these move. Now, let's take this analogy, but let's move it to a hospital. And while those sports fans are heartbroken, doesn't really have a huge impact necessarily on their health outcomes. But if you were in a town, a smaller town, and suddenly, without much notice at all, your major healthcare provider picks up and decides to move and go somewhere else, or just close down. Maybe it's for financial reasons or a variety of reasons. There could be very legitimate reasons they're closing down. But without much in the way of notice, they're gone. So what this bill does is a couple of things. It sets out more provisions and says exactly the steps you must go through, and prescribes a little bit more so that those communities get ample notification and know when a healthcare provider is about to leave. It's been in law. There's also been in the past no penalty for a hospital not following what had already been there. No penalty if they did not do that. So we have had cases where, even though it is in the law, some healthcare providers have decided to not follow that and just go. So it does put in a little bit of a penalty to make sure that people follow that kind of rule of law in terms of whether they are going to pick up or close down their facility. And then it also, at the end, if there is a chance that a local community would want to try to take on that, the running of a hospital or a healthcare facility there, that they also have the option of the first kind of right of sale, as opposed to it going to be sold off for some other means. So it does change that. So those are kind of the major changes on that. And if the amendment is ready, I can also describe the amendment as well. Just a little bit on the amendment. The biggest part of, I will tell you what the amendment is. The biggest part of the amendment is that in the bill, it says that there's They have to change it to 300 days before a hospital or voluntarily plans to implement one of the following schedule actions. After consulting with a few of my colleagues and also talking to some of the hospitals, that's probably too long. Because we're thinking about if those hospitals, if there is a hospital that in good faith is trying to do all they can to stay afloat and they're just not making it, is making them go another 300 days, is that actually the best outcome for anybody? So the amendment knocks that down to 182 days. So it does extend it out still a little bit, but 182 days. And then there are just a couple of other things in the amendment that are just kind of clarifying language on a couple of terms we thought were not exactly clear. But that's the main thrust of the amendment.
Thank you. Yeah, we will be getting it shortly. We will move to your testifiers. First, I have Daniel Clute. Welcome to the committee, and please state your name for the record and begin your testimony.
Good morning, Madam Chair and members of the committee. My name is Daniel Clute. I'm a registered nurse at Bethesda Hospital in St. Paul, which is now gone, of course. The building is torn down, but we are now located in what used to be St. Joseph's Hospital. The St. Joseph's Hospital that was closed down in the midst of the COVID pandemic in 2020. Despite significant mental health needs in our community, which St. Joe's was a lifeline for, despite only having 2 other emergency rooms in St. Paul, these historic, prestigious institutions were shut down, and the outcome was disastrous for local communities and across the state. It exacerbated the ongoing mental health crisis, and it helped ignite the crisis of overcrowding and boarding of patients in emergency rooms. The last time I testified was a few years ago in the House Committee, and I was warning them, pleading with them to do everything that they could to try and prevent the closure of those mental health units. The last units that we had left at St. Joe's that I was working on at the time, because there was no plan in place for how we would take care of those patients in the years-long gap while they build, this monstrosity behind us that's being constructed. And so, unfortunately, as you know, the closures there did happen, and now we're all kind of living with that. And it's not just Fairview. Recently, Alina shut down adolescent mental health services at United Hospital, delivering yet another blow to desperately needed services in our community. They did this under the guise of a service reallocation, strategic reorganization, whatever they want to call it. It's closures, it's reducing desperately needed services to pad the bottom line. The same thing happening now in the North Metro with closures of pediatric services at Mercy Hospital and downgrading the ICU at Unity Hospital. These are desperately needed services being shuttered, and it's bad news for those communities nearby. Outside the metro area, we've seen labor and delivery services on the chopping block as women and families are being told, sometimes in the middle of a pregnancy, that they're going to need to figure out how to arrange everything to deliver their babies several hours from home. And just imagine if there were complications or even a NICU stay on top of that. So nurses have been sounding the alarm on this for years. Hospitals have been racing to the door to divest from many of these core services that are desperately needed to deliver quality health care in our state. And then we have insurance companies posting record profits year over year that are benefiting from that lack of access to care. We do need to actually address the broader issues related to consolidation and closures, which this bill itself does not do. But SF 4382, what it does do is provide needed transparency for communities, patients, workers, and the taxpayers of our state that support the healthcare delivery system. It creates a little bit more accountability, something that's been solely lacking, to make sure that these things are done in the right way for everyone involved. So please help us bring transparency and accountability to this process by supporting SF 4382. Thank you, Senator Kupec, Abler, and Hoffman for authoring this bill and supporting it, and to all the committee members today.
Thank you. Thank you. And Senator Kupec, we do have the amendment. Would you like to move the A1 authors amendment?
Yes, Madam Chair, I will move the A1 authors amendment.
Members, all those in favor, please signify by saying aye.
Aye.
Any opposed? The amendment is adopted. Thank you. Next, we have on Zoom, we have a testifier, Cassie Heidi. And if you can please state your name for the record, and I apologize if I mispronounce your name. Please state your name for the record and begin.
Good morning, Madam Chair, members of the committee. My name is Cassie Heidi, and it's an honor to serve as the city administrator for the city of Foston. Foston is a shining example of progress, growth, resilience with a reputation as a healthcare hub. We have a population of just over 1,400, but we proudly serve a larger community of approximately 20,000. I'm very proud to support Senate File 4382. As city administrator, I've witnessed firsthand the critical need for the proposed revisions to this bill. In May of 2021, local hospital administration informed the city that the OB program in Foston was pausing for 120 days. Upon this news, we quickly formed an OB task force made up of 14 community stakeholders willing to participate in assisting Essentia's restart of OB. After 12 months of meetings and continuing to meet the goalposts that Essentia set, we soon began to realize that Essentia did not intend for our OB program to resume and actively worked to create the problem they hoped our community would perceive them trying to fix. Fortunately, because of the hard-fought, solid agreement leadership in 2009-1, the city has a remedy to ensure that our community members have the access to care that they deserve. What makes this revised bill so important is seeing what Essentia was allowed to do in Foston with little to no repercussions or accountability. Essentia Health's mandated public hearing under the current bill was held via Teams meetings 606 days after babies stopped being delivered in Foston. Over 200 people attended that hearing, with more than 40 people at City Hall attending. Our questions were limited, and the moderator coached Essentia leadership on several questions, leaving those in attendance frustrated with the process. The current bill points to a provision of a potential $1,000 fine. The revisions to this bill will institute penalties that actually carry weight for multi-billion-dollar nonprofits, ensuring accountability and consequences commensurate with their actions. The language in this bill will fulfill what I believe the original intent behind its passage was, and that is providing the public with the notice and transparency they deserve. It will ensure healthcare corporation executives engage directly with the community, facing the individuals in the communities whose lives are impacted by their decisions. Finally, the language in this bill empowers local governments to shape the future of healthcare within their communities. Local governments have an intimate understanding of community needs that far surpasses that of corporate executives, whose profits often exceed double the general fund budget of the communities they serve. I'm here because this means something to me and the people I serve. I'm here to help be the change, a motto I strive to live by every day. I'm willing to help in any way I can. I thank you again, Madam Chair and members of the committee. I'd also like to extend my gratitude to the Minnesota Nurses Association for their dedication and commitment to providing health care we all deserve, a true quality innate to nurses. And finally, thank you, Senator Kupec. I loved your analogy, and thanks so much for giving me the time today.
Thank you very much for your testimony. Next, we will have we have in-person testifiers, Justin Stoffren and Eric Imler, if you could come forward. Welcome to the committee, and please state your name for the record and proceed.
Thank you, Chair Wiklund and committee members. My name is Justin Stoffren. I'm with the Minnesota Farmers Union, which is a grassroots organization that's represented family farmers, ranchers, and rural communities throughout Minnesota for over 100 years. At our most recent annual convention, our members voted to make ensuring affordable and accessible care in rural Minnesota as a top priority. That's why I appreciate the opportunity to testify today in support of Senate File 4382, which will help address a key consequence of hospital and health system consolidation, which is the closure of hospitals and the loss of critical healthcare services in communities. We've submitted a letter to committee with all sorts of facts and figures. It's good bedtime reading if you need it, but I wanted to focus on a couple of perspectives from members of ours that couldn't be here today. Ann Schwagel is MFU's vice president and farms with her young family in Big Stone County. And between Big Stone and the neighboring county, there's one hospital that provides OB care. And as Ann has said, quote, "It's difficult to raise a family and ensure the next generation of family farmers in rural Minnesota if there's nowhere to deliver babies." And of course, Ann's experience is unfortunately not unique, as we've seen the number of hospitals offering birth services drop from 110 down to 76. Dr. Dana Seifert and her husband farm in Scott County, and Dr. Seifert is also a physical therapist at an independent clinic in St. Peter. In her decade of experience in healthcare, she's seen firsthand the impact of consolidation on our healthcare system. Dr. Seifert has said in testimony that, quote, "Minnesota will be better served by a larger fleet of right-sized healthcare organizations, not a dwindling number of lumbering behemoths with too many layers of management between the people making decisions up in the C-suites and the providers on the front line serving patients." Senate File 4382 offers a chance for communities to protect and control local healthcare infrastructure and take steps to fulfill the vision laid out by Dr. Seifert. Members, in conclusion, 3 decades ago, Minnesotans spent less than the national average for hospital care, with a system that was less consolidated, more distributed, and provided greater access. Today, Minnesotans spend more than the national average for a highly consolidated system with less access. Senate File 4382 is one part of reversing this trend. I want to thank Senator Kupec for his leadership in bringing the bill forward and thank the committee again for the opportunity to testify.
Thank you very much. Mr. Imler, please state your name for the record and begin.
Thank you, Chair Wiklund and members of the committee. My name is Eric Imler. I live in Minneapolis. I have worked in inpatient mental health at M Health Fairview Riverside for the last 5 years. I'm here to testify in support of Senate File 4382 on behalf of my union, SEIU Healthcare Minnesota and Iowa. Our union represents over 50,000 healthcare workers across the state. Whether you live in Minneapolis like me or in greater Minnesota like Senator Kupec, everyone needs reasonable access to the medical services we all need to survive and thrive. But too many Minnesotan communities, both large and small, lose their local medical services because healthcare executives choose their bottom line over our health. This bill does not take away ultimate authority from healthcare providers. It allows for them to retain final authority to run their businesses. Instead, this bill makes it more likely that these decisions will be made open with public input. As we heard, we've seen this in mental health before, the consequences. Minnesota lost access to 105 inpatient mental health beds when Fairview St. Joseph's closed, and 18 beds when Fairview Southdale closed Station 77. Cities, patient advocates, law enforcement agencies, and other hospitals pleaded to not close these units. In total, we ended up losing 20% of community inpatient beds for all of Minnesota. What you probably haven't heard since then is that Fairview has reduced another 30 to 40 inpatient mental health beds at Riverside, where I work. First, they moved or temporarily reduced 14 beds on our adolescent crisis stabilization unit, Unit 3C. Then they reduced and combined 18 beds on our adolescent dual diagnosis unit 6A with another pediatric unit. These reductions then became permanent, and our remaining 2 pediatric adolescent mental health units were also capped. The closures combined with the cap resulted in a pediatric department with over 60 licensed mental health beds that only serves up to 21 patients. Now, when asked if we will be increasing the patient cap anywhere close to where it was, Fairview says they only expect this to rise to the mid-20s in terms of beds. They claim we are meeting the needs of the community. I disagree. My colleagues and I feel like we didn't know what was happening and kept hearing what was now what now seems like half-truths. Like us, I imagine, communities would have appreciated more notice and transparency. We brought up the reductions we were seeing at Riverside to other public meetings around reductions to the Department of Health, but we received no follow-up from the department. At this point, though, it seems like the fault is not with the department, but a weakness in the law. We have not yet had a hearing about these closed units. I have a hard time imagining our closures, and I'm hearing, are the only ones being swept under the rug. Please, I urge you to support Senate File 4382. Thank you all for your time.
Thank you very much for your testimony. Last, I have Mary Krinke. Welcome to the committee, and please state your name for the record and begin.
Thank you. Madam Chair and members of the committee, for the record, my name is Mary Krinke, and I'm with the Minnesota Hospital Association. The last thing the board of directors of a hospital want to do is to close the hospital. This is really hard on the patients that they serve, the employees that they have, as well as the broader community, as Senator Kupec said with his beloved football team. But the problem, and I hope people understand this, that as soon as the announcement is made that a hospital plans to close, the staff, and you can hardly blame them, they immediately begin looking for other positions and other jobs. And so what happens to that hospital once that announcement is made, staff from all levels begin to leave. So it would be very difficult for the hospital to provide services much past that 120-day time frame that is in the current law right now. We are appreciative of Senator Kupec's amendment that dropped that 300 number down to 182. That is certainly an improvement, but I don't know that the hospital can stay open with a skeleton staff. So I still think that this is probably going to be problematic. I also want to talk a little bit about service line closures. Service line closures usually happen for three reasons. Number one is safety and quality concerns. Number two is financial hemorrhaging if the hospital can no longer subsidize that service at the same level. And number three, which is by far the most common, is because of lack of specialized physicians that we need, particularly psychiatrists and OBGYNs. So many of these communities recently have just not been able to recruit the specialists they need to keep the services operating. I want to give you an example from the Fergus Falls Hospital that recently announced it was closing its inpatient mental health unit. Prior to 2022, they employed physicians there at the hospital directly, and they provided inpatient staff. The psychiatrists were older, and they retired. Since that time, then, the hospital has contracted with the local Lake Region Medical Group that provided inpatient services. At the end of the year, the group told the hospital we would no longer be doing inpatient services. We're only going to be doing outpatient services. So the hospital began frantically trying to find a psychiatrist, and they could not. So they made the announcement that they were closing their inpatient unit on March 15th. I use that as an example because that is usually why these closures are happening. I want to mention two other things in the bill. One are the financial penalties and the right of first refusal. The way the bill is written, there are 19 new requirements for posting and transparency, and we are actually very comfortable with most of them. That's the good news. There's only one that I think is a little problematic, and that says that you have to contact all statewide media. I think for a hospital to contact all statewide media, we're not really sure what that would mean, so we would prefer that to say local media. But the way the bill is written, it's a $20,000 fine for each time the hospital might mess up posting this or alerting this or doing something. So we're hoping that that would be a cumulative rather than the 19 new requirements. Also, the bill says that the Department of Health must impose the penalty difficulty rather than may, and there's no opportunity for a corrective action. And the last thing I want to mention is the right of first refusal. And I know that a lot of local units of government may like this opportunity to buy a hospital, but it may actually be the best thing for the community if the hospital, rather than closing, perhaps is purchased by a larger healthcare system. So I'd be very cautious on doing that right of first refusal. Local governments may not be able to operate a hospital. So thank you, Madam Chair.
Thank you. Now, members, do you have any questions or comments? Questions or comments for Senator Kupec? Senator Abler.
Thank you, Madam Chair. I'm sorry I missed the discussion, but the SRO Conference Committee is coming back to the Senate in the version that the House offered. So that matters, but done with us. Just a comment I mentioned briefly in my original comments, I just want to mention. So when we close places, who has a duty to serve the people who aren't going to be served? And I mentioned my local thing. So let's just say we close an OR at Unity and now Mercy doesn't have room. What are you going to do then? With all these consolidations and closings and now it's economically feasible, what's going to happen? Closing pediatrics at Mercy. Oh, Children's has got that. Well, this Children's got the capacity. And so I really worry about this, and I'm not sure if the bill even handles all that, but the topic is really important. And at a time when more and more major decisions are made by fewer and fewer people in a room that we don't know where the room is at. And I'm not criticizing any companies. I just live in an area where they're closing pediatric mental health as well. We talk about that all the time. And so who's going to handle the load instead of just saying, oh, it's going to be fine. So anyway, Senator Boldon, Senator Boldon. This is Senator Boldon. Senator Kupec, I just can't tell you apart sometimes. Thanks for bringing the bill forward. Thank you.
Thank you. Senator Udke.
Thank you, Madam Chair. I do have some questions on this. And first of all, Senator Kupec, I like your the way you started out going back to the Baltimore Colts and the Whalers. That comes from a generation we understand.
Sure.
There's some that maybe are much too young for that. But anyhow, on the first page and right before where you change the number of days, when it talks about that the hospital campus must notify the Commissioner of Health, the public, and others. Who would others be? And I guess, is that in statute? I mean, others seems to be anybody and everybody. I think that's a little broad.
Senator Kupec.
Sure. I think the others is getting at, the list that is further down in the bill in terms of talking about local media and other stakeholders. So I think that's where the others comes from. But I understand, Senator Ike, what you are saying. It is maybe a little on the vague side, but I think it's referring to the list that's further back in the bill.
Senator Udke.
Thank you, Madam Chair. And I do think that if this was to go forward, we probably should do something with that because we know what happens when we leave the door wide open. And then Ms. Krinky did take and touch on some of the things that I was going to talk about too, and that was the number of days. It changed to 182 days, but and even as Senator Abler has been talking about things that are here in the metro, but when we go out to our rural areas, we don't even have the options to go suburb over, 2 suburbs over. So within driving distance, now we're talking 40, 50 plus miles between facilities, and in most cases a lot more. That even the 182 at that rate is very troubling because if one of our small hospitals closes, that staff is going to be looking instantly to where they can find their next job. And I mean, that's only human nature. So after you get past, I would think 120 days is a lot. So if we start to get out beyond that, somebody's going to be there to probably clean the building, but that's going to be it. So I don't know where that lands, but that is a concern in our small rural hospitals. And if they do get to the point that they're closing and need to use this, they've exhausted every last thing to keep their doors open. the last thing they want to do is cut services to our areas. I mean, in a small town, you have a hospital, you have a school, and a post office. As you start pecking away and losing those, if you lose all three, you don't have a community anymore. And so that's how important the health care is. That's why I don't know that this is a big part of it. But a couple other questions. Yeah, and again, it's been tough. That statewide media kind of is the same as that others at the beginning. I think that's awful broad, because if it's in Park Rapids, we wouldn't need to have it in a statewide media. We got enough local ones that definitely could take care of. And then I had, going back to page 4, on line 6, and it talks about the telephone number. Now it was changed to the email address. Okay, that clears up the chief executive officer is what I was concerned with, and if we were putting out addresses, but email address is acceptable because that's a public thing already. With that, most of my concerns have been covered. Ms. Krinke again covered them. The $20,000 is, I think, really a bad deal, because if they're already on, I mean, they're closing because they can't make it work. What good's a penalty to further burden them? But with that, thank you, Madam Chair.
Thank you. Members, any other questions? Senator Liskey.
Thank you, Madam Chair. Madam Chair, Senator Kupec, this bill actually hits pretty close to home. I live in the city of Lonsdale. The Northfield Hospital Systems unfortunately closed the Lonsdale Clinic not too long ago, and unfortunately not with a whole lot of notice. The community is not too happy, and they're definitely struggling on the healthcare access, because now it's at least 20 minutes to a primary care provider. So this is a pretty big deal. So in some ways, I'm in support of this, because it does give our patients and my constituents, you know, some leeway, and hopefully it would have helped solve the situation. I do have a question about Section 6, the right of first refusal for the sales section. Based on how I'm reading it, it's allowing the city or the municipality or whoever's in charge to purchase it, and that's actually a concern, because that's exactly what happened in Lonsdale, and now they're going to be turning what was a hospital clinic system into a city hall. So that's not really ideal when we lost our health care and now we're turning it into a city hall building. So something that I'd maybe want to look into with you about how that can actually work out. So maybe if you want to address that, or how we want to talk about that.
Senator Kupec.
Sure, absolutely, and I think you know what this is really getting at is having that community have that ability to have that conversation about what they want to do, and ideally, I think any community that if there was some other hospital or healthcare organization that wanted to take over, I'm sure they'd be like, yes, please come in and do that. But I think it's a community asset, whatever that building is. And so as a community, how they can come together and figure out how that can best go on to serve the public, I think that's the best case. And I don't, you know, in your communities, maybe that's their decision. But again, that is keeping it at a local control issue, I guess, as opposed to mandating what it is. So it does just give them the right of what is a fairly large, you know, probably building, and keeping that as a community asset, or having it just go away.
Senator Liskey.
Thank you, Madam Chair. Madam Chair, Senator Kupec, thanks for addressing it. I know that personally, I think it's actually a great location for City Hall. The issue is that we now have no buildings for a new clinic system to open up in. So it's kind of a catch-22, or, you know, referencing sports some more for you. And I love hockey. I knew who you were referencing, even though I'm not quite old enough to know the Hartford Whalers. But go Hurricanes. Anyway. With that being said, I appreciate what you're trying to do. So thank you.
Thank you. Any other member questions or comments? I'll just say, I think, you know, what we've got in place today just isn't sufficient. You know, we have some notification requirements, but they're not they're not really backed up by accountability for following through with them. And I think I appreciate your bringing the bill forward and continuing to have the discussion about how do we make sure that there is transparency. And, you know, I understand that there are business decisions that have to be made, but I think that communities, you know, their experience of losing healthcare is certainly impacting their lives. And so I think there's some accountability there too for impact on the community. So I appreciate your bringing it forward. And do you have any final comments?
Sure. Thank you, Madam Chair. Thank you, members of the committee, too, for the discussion. And I agree. I think maybe we'll, before we go on anywhere else, too, we'll change that to local media, because that is a legitimate also concern. And to Senator Liskey, I will tell you that the Hartford Whalers fight song is my ringtone on my phone. So that's where we're at.
That's deep, yes. Very deep.
I could play it for you right now, too, if you'd like, Madam Chair.
That's okay. Well, thank you, Senator Kupec. We have found that we do not need to send this bill to judiciary. We are able to keep it in our committee, and so Senate File 4382 will be laid over for possible inclusion in an omnibus bill. And members, now we will be recessing until our evening agenda, and we will begin again at 6 o'clock in this building, in this room.